Good evening, and thank you for joining us for tonight's Asthma Medication 101 webinar with Dr. Holly Mansell. My name is Jill Hubick. I'm a registered nurse and certified respiratory educator with the Lung Association of Saskatchewan. It is my pleasure to welcome you and to be your host and moderator. As we gather here today, I want to acknowledge that I am hosting this webinar on Treaty 6 territory and the homeland of the Métis. We pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationships with one another. Before we begin, on behalf of the Lung Association of Saskatchewan, I would like to take a moment to acknowledge the healthcare providers and the champions in lung health. We truly appreciate their services, not only to their patients, but also the services they have provided to many of us and the support they've provided to many of us, and the above and beyond efforts that they have undertaken during the pandemic. Tonight's presentation is sponsored by GlaxoSmithKline, GSK, a science-led global healthcare company with a special purpose: to help people do more, feel better, and live longer. I am pleased to welcome Marie-Claude from GSK to bring greetings.
Good evening, my name is Marie-Claude Desaulniers and I work in Patient Affairs and Engagement at GSK. On behalf of GSK and our respiratory team, we are pleased to support the Lung Association Saskatchewan and this educational webinar on asthma medications. Knowing the burden of those living with lung conditions, this is really what drives us at GSK to fulfill our mission to help people do more, feel better, and live longer. We also want to thank the Lung Association Saskatchewan for this opportunity to be part of this great initiative to educate and support patients and their loved ones. Before I conclude, we want to recognize the strength, ability, agility, and flexibility of the Lung Association Saskatchewan through the pandemic. They've been able to support their community, healthcare professionals, patients, caregivers through tough times. They've been able to keep growing as an organization and to keep delivering their mission. Really inspiring. Bravo. Thank you very much, everyone. I wish you a very nice evening. Bonsoir. Merci beaucoup.
Thank you, Marie-Claude. Tonight's presentation topic was requested by our Lung Association of Saskatchewan Asthma Support Group members. Our online support group shares asthma education learning opportunities, up-to-date evidence-based information, and it's also a safe place to come together and share your asthma journey. Please consider joining the Lung Association of Saskatchewan's Asthma Support Group by visiting our website at lungsask.ca. Our presentation tonight is very timely. It is occurring during the September spike, the sharp rise of asthma emergencies and flare-ups that occur each and every year in the third week of September. We want everyone living with asthma to be well controlled, not only to avoid the September spike, but so people with asthma can live the best life possible all year round. This past year, the Canadian Thoracic Society has provided new guidelines for asthma control and new guidelines for medication criteria for mild asthma. Do you know if your asthma is controlled? Do you have questions about your asthma medication? The presentation this evening with Dr. Holly Mansell on asthma medications and asthma control will give you knowledge and more power to help you live your best life. Following the presentation, we will have time for a moderated question and answer period. If you have questions for Dr. Mansell, please type your questions into the chat feature on the webinar software. You will find this feature in the control panel on the right side of your screen. Don't be shy. Don't be scared to ask your question. Chances are someone else has the same question as you. So now it is my pleasure to introduce to you tonight Dr. Holly Mansell. Holly Mansell is an associate professor at the University of Saskatchewan. She spends her time teaching and performing research primarily in the areas of transplantation, patient education, and pharmacy practice. She is also a pharmacist and works at the Saskatchewan Transplant Program with an interdisciplinary team. She received her Certified Respiratory Educator designation last winter and enjoys educating both pharmacy students and patients with respiratory health, health disease and concerns. So please welcome Dr. Holly Mansell.
Hello everyone, and thank you so much for joining me this evening. I know just how crazy September can be, and on top of that, many of you have children who are starting school and activities, and so I'm so honored that you took time out of your evening to be here to join me on this webinar about asthma medications. And so, as was mentioned, my name is Holly Mansell, and I'm a pharmacist by profession, but these days I spend most of my time at the University of Saskatchewan either doing research or educating pharmacy students. And so tonight I'm going to give you an overview on asthma medications and kind of the same approach that I would take with my students. And we're going to cover the major classes of drugs, how they work, and when they should be used to sort of help you achieve optimal asthma control. Now, I'm sure that most, if not all of you, have your own healthcare team of providers, and you probably have a physician, maybe a pharmacist, a nurse, or a respiratory educator. And these individuals help you or your loved one to manage your asthma. And so I'll be covering asthma in more of a general sense, and I'm certainly happy to take questions about the medications or anything I cover, but we'll have to leave the specific questions about your own personal situation for your own healthcare provider because they're the ones that manage your care and know you the best. So with that, we'll get started. And the first thing I want to go through is the learning objectives. So tonight we're going to describe what optimal asthma control looks like. We're going to compare and contrast asthma medications. And then we're going to discuss inhaler technique and medication adherence and why they're so important. And then finally, we'll sort of wrap up with reviewing the proper use of some of the more common inhalers. So before we jump right into any medication-related topic, it's always important that we talk about the medical condition. Because as I tell my pharmacy students, how can you expect to understand the medications if you don't understand what it is that you're treating? And so I'm guessing that most of you are here today because either you have asthma, your child has asthma, or a loved one has asthma. And for many of you, this information will be basically a refresher, and I'm sure you know a lot of these things. But let's just start at the beginning. So first off, asthma is extremely common. It affects 3.8 million Canadians over the age of 1 year, and it is really the top chronic condition in Canadian children. So every day, 317 people are diagnosed with asthma, and 290 people suffer from an asthma attack that requires emergency care. And children with asthma have actually been shown to have 3 times more hospitalizations than that of the general population. As you also know, asthma is a disease that affects the lungs. It causes repeated episodes of wheezing, breathlessness, chest tightness, and coughing, which can be either in the nighttime or early morning or throughout the day. And if someone has asthma, they will have it all of the time, but the attacks will only occur when there's something around that's bothering the lungs. The next fact, asthma is sneaky. And the reason I say that is because the symptoms vary from person to person. So you'll have one person that can have just mild bouts of occasional breathlessness, and then you'll have another that will have daily wheezing despite continuous high doses of medication. And the other thing is that the symptoms can vary from day to day, even within the same person. When patients have symptoms of asthma, they usually come and go periodically. But when those symptoms are active, it's called an asthma exacerbation or an asthma attack. And these symptoms stem from inflammation and tightening of the airways. So during an asthma episode, the airways become extremely narrow due to the muscle constriction or bronchoconstriction. And you can see here, this is someone with normal airways, and this is someone with asthma. So you can see here the narrowing of the airways, and not surprisingly, that leads to compromised airflow, and even if it's not treated, it can lead to an unexpected fatality. Another fact about asthma is that symptoms are triggered, and they're triggered by stimuli. So endogenous stimuli are those that are generated inside the body, so things like stress or hormonal fluctuations or perhaps GERD, gastroesophageal reflux disease. And exogenous stimuli are those that are generated outside the body. So things like exercise or allergens or irritants that are shown in this picture here. So things like pet dander, air pollution, cigarette smoke, and many others. And the thing about these different triggers is that they're different for everybody. Everybody has their own specific triggers that are unique. Asthma cannot be cured, but its symptoms can be controlled. And in fact, it's actually a very treatable condition. We now have very good medications that can help control the inflammation that causes asthma and essentially can help someone lead a normal life. But unfortunately, 6 out of 10 people with asthma do not have control of their condition. So what are the common reasons for poor asthma control? Well, there's many, and I've just listed some of them here. So first off, it could be perhaps the person is not using their inhalers properly, or perhaps they're being exposed to a trigger that's causing the symptoms and making them worse. It could also be from not using the right asthma medication, or from not using a controller medication regularly, which helps to control the inflammation. And then, of course, something else might be triggering the symptoms as well. So, for instance, if someone with asthma maybe has an infection, this could be making things worse, and a different medication may be needed in addition to the asthma medications. So how do we know when asthma is well controlled? Well, in order to answer that question, I'm going to digress just for a moment, and I'm going to tell you about the CTS, or Canadian Thoracic Society. So this is Canada's professional organization which promotes lung health and provides best respiratory practices. And so this is the group of healthcare providers and researchers that come up with these clinical consensus guidelines on how to diagnose and manage asthma. And so this is an example of one of the position statements and guidelines. And you can see here, this is from 2021. And so the most recent guidelines for asthma management were actually created in 2021. And they've come up with some new changes to how we think about asthma. And so that's what I'm going to highlight on the next slide. So this is a CTS definition of asthma control. So on the left-hand side here, we have the characteristic. And on the right, we have the frequency value. So you can consider your asthma or your loved one's asthma well controlled if you or they have daytime symptoms that are no more than 2 days per week. So that means you are not needing your rescue inhaler or your reliever inhaler any more than 2 doses per week. Nighttime symptoms, we want them to be less than 1 night per week, and we want them to be mild. We want physical activity to be normal. We want exacerbations to be mild and infrequent. So again, what do we mean by an exacerbation? Well, that's really an increase in symptoms from baseline that doesn't require any sort of systemic steroids or emergency department or hospitalization visit. We also want people to be able to go about their daily activities and not having their asthma affect what they're doing. And so no absences from work or school due to the asthma. And then these ones here at the bottom, you can see they're in red here, and I just put them in a different color because not everybody will be monitoring for these symptoms. Some of these things will be monitored by a physician, perhaps. So for instance, spirometry, we want it to be at least 90% of the personal best. Or some people will be monitoring using a peak flow meter, and again, that would be at least 90% of the personal best as well. And PEF diurnal variation, that means kind of your symptoms over the night. We don't want that to fluctuate too much. So less than 10 to 15%. So how can we control these asthma symptoms? Well, there's basically two sort of parts to treatment. And so the first one is the non-pharmacologic therapy. And this is just as important as the pharmacologic therapy or the drugs, which we're going to get into next. So what we want to do is identify and avoid triggers. So as I mentioned, everybody's triggers are going to be different. And so we need to find out what is the trigger for you or your loved one. So if it's animals, we want to minimize exposure to that type of animal. If it's mold or fungus, we want to be able to avoid that as well. Some people have dust mites or outdoor exposures like pollen or grass, pollution, different things like that, or fumes. And so again, avoiding those if possible. Stopping smoking is a big one. Smoke is a big trigger as well. And then finally, some people can have different problematic foods or additives or medications that can be a trigger. And so if that's the case with that patient, we want to make sure that they are avoided. So we call avoiding those triggers environmental control. And reducing or eliminating those different exposures to the triggers in both the home or the daycare or the workplace or the school or wherever the person spends the most of their day is really, really important. And the reason it's so important is because, first off, that can decrease the need for pharmacotherapy or medications. It can decrease asthma symptoms. And if we don't do different sort of things to decrease the triggers or eliminate the exposures, then we will end up with worsening airway inflammation and a decrease in the asthma control. So these triggers should be reevaluated over time because they can actually change. And we want to try and do our best to eliminate every kind of exposure we can. So not just one thing, but doing everything we can altogether. And that works the best. Okay, so moving on to pharmacotherapy, which is really why you're here today. And this is just a fancy word for medications or asthma medications. Traditionally, we've categorized asthma medications according to relievers and controllers. And so relievers are otherwise known as rescue medications, and they do just that. So they provide fast but temporary relief of that bronchoconstriction or tightening of the airways, and they do that by relaxing the muscles that have tightened in the airways. However, they don't do anything to help with that inflammation. And so most bronchodilators will open the airways and they'll help to restore the breathing within 10 to 15 minutes. And the effect of that lasts usually for about 4 hours or so. So every person who has asthma should have a reliever medication on hand and know when and how to use it. So that's just that point right there. Should have on hand at all times, but take only when needed. So you take it during an attack or during an episode of shortness of breath, or perhaps before you're doing something that's going to trigger the symptoms, like perhaps before exercising. The other class of medications, or the other group of medications, I should say, is the controllers. And these are medications that actually do work on the inflammation and they work to prevent the asthma attacks. And so these are medications that have been traditionally taken every day, even if there are no symptoms. And they act slowly and they work over the long term. So unfortunately, they don't help in an asthma attack, but they do help with that underlying inflammation. So they actually get to the root cause of what's happening. So this slide is quite busy, and it's just kind of an overview of the different classes of medications and where they fit. So we have relievers, which are our short-acting beta agonists, and we're going to talk about those next. We have our controllers, and the biggest class we use there, or the most important class, are inhaled corticosteroids. And then we have several other add-on medications that can be used as well, and we'll go through those as well. And then over here on the right here, we have one other sort of different one, and it's a reliever and a controller together. And so this is a new product that we have, which is an inhaled corticosteroid and a long-acting beta agonist, which opens up the airways together in one dosage form, and that's called Symbicort, and that's used a little bit differently. And so that's a combination of budesonide and formoterol. And so lots of big words on this slide. I know it's very confusing. Drug companies don't make it easy for us. They pick sometimes the hardest names they can think of. And another thing that makes it tricky too is that drugs have more than one name often. So they have the generic name, which is the chemical name, the actual drug that's inside of the inhaler or the device or the dosage form. And then a lot of them have a brand name as well, which is, of course, the way that the company manufactured it. So using the analogy of pants, jeans would be the generic name and Levi's would be the brand name. And so throughout this presentation, I'll be using the generic name And the exception to that would be Symbicort here because it is a combination product and it's just too hard to say over and over budesonide formoterol. So the first class of medications we're going to talk about are the short-acting beta-adrenergic agonists. And this is a big mouthful as well, I realize. And this is our reliever class of medications that we talked about. So it's over here on this side. And so these are medications that produce bronchodilation. So they basically reverse that bronchoconstriction that we talked about. And they do that by stimulating beta receptors in the body. And those beta receptors are still the same receptors that are involved in your fight or flight response. So let's say you get scared and you need to run away from something really quickly and your fight or flight response kicks in. It's those same receptors that are stimulating that open up your airways so that you can breathe faster, so that you can run away. So yeah, same sort of system here. So unfortunately, as I mentioned, these medications don't have much effect on inflammation. And so that's why they're primarily used for relieving the symptoms quickly, but not for preventing the symptoms. So I have here, it's used for quick relief of cough, chest tightening, wheezing, and shortness of breath. So any of those symptoms. And so you're going to use them when you're experiencing the symptoms or before you have exposure to something that's going to cause the symptoms. So if we think of how the drug works, that helps us to kind of think about the common side effects. So let's think about your fight or flight response. What are the things that you experience when you're, nervous and running away from something? Well, flushing, lightheadedness, trembling, nervousness, increased heart rate, those are all things that can happen. And similarly, those are things that can happen from using a short-acting beta agonist. On this slide here, I just have some examples of a short-acting beta agonist and what they look like. So the first one here is salbutamol, and then the brand names are in brackets here. And then the next one is terbutaline. And so you can see that they're most commonly, but not always, in a blue device. Just a few points about short-acting beta agonists before we move on. So first off, their dosage. So they're usually dosed 1 to 2 puffs every 4 to 6 hours as needed. And we only use them when needed, as we talked about. Also, if we're finding that we're needing them more than 2 times per week, then that is an indicator that we should see the physician. And that's because that can indicate that our asthma is not well controlled. And again, that was from that chart that we looked at about asthma control. What makes your asthma well controlled? We also talked about this. So some people will use their rescue medication 15 minutes or so prior to their exercise or their trigger to kind of prevent those symptoms from happening. So just a couple of points here about short-acting beta agonists before we move on. So first off, the dosage. So usually they're dosed 1 to 2 puffs every 4 to 6 hours as needed. And again, we only use them when they're needed. The next one, if we need to take the reliever more than 2 times per week, then that means we should see a physician or healthcare provider. And that's because that indicates that the asthma is not well controlled. And we learned that when we talked about the asthma control criteria that came out from the CTS. So again, we talked about this as well. Some people will use their rescue medication or their reliever 15 minutes prior to the exercise or trigger that will cause the symptoms to kind of prevent them from happening. And then finally, one last point that we haven't covered yet. During a serious asthma attack, it's safe to use puffs every few minutes. And I put that down there because we would never want to say to someone, oh, you've already had your 2 puffs in 4 hours, so therefore you're done. If you're having a serious asthma attack, the most important thing is getting those airways open. And so it is safe to take puffs every few minutes until the ambulance came or medical help came. So now we're going to move into the controllers. And I should just start off by saying that almost everybody should be on a controller medication unless their symptoms of asthma are very, very minor, very mild. So the first class is the long-acting beta agonists. And so not surprisingly, these guys work very similar to the short-acting beta agonists. They work on the same receptors. However, they work longer or over a longer period of time. So they work slowly over a 12-hour period to keep the airways open and the muscles relaxed. Their side effects are similar to the short-acting beta agonists, but a couple of key differences here. So first off, they require daily use. Again, they're a controller, so they require that daily use to work properly. and they're never to be used alone. They're always added on to inhaled corticosteroid therapy. And then finally, just a little point here at the bottom, the exception to this is formoterol. Formoterol can also be used as a reliever in addition to a controller. And again, we talked about Symbicort, that combination product of formoterol and budesonide, and we're going to talk about that a little bit more coming up. So these are just some examples of our long-acting beta agonists. So salmeterol comes in the Ceravent discus and formoterol. So the next class of medications is our inhaled corticosteroids, and these are unequivocally the most common and effective type of controller that we have. So everyone with asthma, even those with mild asthma, can benefit from the regular use of an inhaled corticosteroid. And when they're used regularly, they have all kinds of really good benefits. They improve lung function, they decrease the frequency and the severity of asthma attacks, they improve quality of life, and they decrease asthma mortality, which of course is very important. They also make the lungs less sensitive to triggers. And they do this by inhibiting the inflammatory response in the body at all levels. So the inflammatory system is really complex and there's so many different things going on, but the inhaled corticosteroids work to kind of tamper that. Now, one of the things that's a downside of the inhaled corticosteroids is they take time to work. So they have no effect on those acute symptoms of shortness of breath, and it really does take time for these steroids to kick in. The onset of effect is days to even weeks, and so patients have to know to use these inhalers regularly and to continue using them until they start to kick in. And so using them over the long term will help control that asthma. Now, in general, they do require daily use, and our exception again here is Symbicort, which we will talk about coming up. So what are the side effects of inhaled corticosteroids? Well, they're going to be dependent on the drug that we're using, the dose that we're using, and also the patient's inhaler technique, which we will talk about in a little bit. Now, because these drugs are given through an inhaler, they're inhaled corticosteroids, they're going to have less side effects than if we gave them in a pill form. And so the most common side effects are hoarse voice, sore throat, and cough. And another one that we typically think about is a mild throat infection called thrush. And one of the things that we can do is rinse our mouth out after we use the inhaler, and that eliminates the risk of having thrush or decreases the risk. And another thing we can do is use a spacer, which is something else we're going to talk about in a bit. So one of the things that sometimes people are concerned about is just that word steroid. It's kind of a scary word. So corticosteroids for asthma are not the same as muscle building steroids that some athletes can use. Those are actually anabolic steroids, and they're a totally different kind of steroid. So corticosteroids used to treat asthma are not the same thing, and they don't have the same risks or side effects. One of the side effects that many parents are often concerned about is growth slowing in kids. And so inhaled corticosteroids used over the long term can have a slowing of growth effect on kids. Now, that being said, what we're finding is in total it's very, very minor, and it usually happens kind of within the first 6 months to 1 year of treatment, and then it has eventually this kind of tapering effect and a very little effect on the adult height. So we're talking like less than a centimeter. And the other thing to consider is if you have a sick child that has uncontrolled asthma, that's also going to affect their growth patterns as well. And so the risks of using inhaled corticosteroids are definitely outweighed by the benefits. It's much better to have your child on an inhaled corticosteroid and have the asthma well controlled. So here's some examples of our inhaled corticosteroids. We have fluticasone, budesonide, cyclosinide, and mometasone. So moving on to the next class, we have our oral or IV corticosteroids. And so, as I mentioned, there are more side effects when we use a corticosteroid by a pill form than when we use it by an inhaler. And so, as such, we're only going to use this route when we absolutely need to. So the use is for short periods of time in acute severe asthma. So really when you're having an episode that needs to be treated. And even then, we're going to try and use it for as short a period as possible. So side effects from using short-term oral corticosteroids are going to be things like insomnia or difficulty sleeping, perhaps increased activity, you almost feel charged up, mood changes, sometimes water retention or hyperactivity, especially in children. Now, these are going to be side effects that sort of are worse the longer that you're on it. And we find that children and people who are elderly are more susceptible to these effects. And so if we're going to use them long term, we'll taper them off and kind of lessen those side effects. But for the most part, we're really going to use the oral corticosteroids sparingly in asthma, only when needed. And this is just some examples of some of the corticosteroids you might see. So prednisone, prednisolone, dexamethasone. So they can be in pill form or solutions or IV forms if you absolutely needed an IV form as well. So the next class of medications is the leukotriene receptor antagonists. And these are controllers as well, but they're not as good as inhaled corticosteroids. And so they're not usually used first line. They're usually prescribed in combination with an inhaled corticosteroid for patients perhaps who have continued symptoms, or maybe instead of increasing the dose of the inhaled corticosteroid, this could be added on. Sometimes they're used for allergic rhinitis as well. So because they're controller, they do require daily use, and I have their variable response because it really depends on the person as to how well this works for them. They work by blocking the effects of leukotrienes, eosinophils, and other inflammatory cells. So again, they help with that inflammation. And in general, they're quite well tolerated. The side effects are quite mild. So you might hear about things like headache or dizziness, maybe some heartburn, but in general, very well tolerated. And the interesting thing about this is it actually comes as a pill and not an inhaler. So I have two medications here, and the top one is actually crossed out because it's no longer on the market. And so now we are left with montelukast or Singulair as the only one on the market. So there are other add-on controllers that can be used if needed if a person is still having symptoms despite these other medications that we talked about. So the first one is tiotropium, and that's a long-acting muscarinic antagonist, and that comes as an inhaler. Another one you may have heard of is theophylline. And that's actually a really old medication and it's rarely used anymore. And that's because it's not as effective as some of the other medications that we have. It's got more side effects, more drug interactions, and it requires blood level monitoring. And that one actually comes as a pill. Now, you also may have heard of biologics. And so these are some of the newest medications that we have, and they're for the treatment of moderate to severe asthma. And so each of these different medications that I have listed here is designed to sort of target and block a particular part of the immune system that's involved in allergic reactions and asthma symptoms. And so these are generally only considered under the advice of a specialist or a doctor that really has a lot of experience with asthma. And they're an add-on option, and they don't replace the existing controller and reliever medications, although perhaps some people can maybe reduce their doses when they're on a biologic. Biologic treatments are generally given as an injection at the doctor's office or a clinic or hospital, and they're usually given every 2 to 4 weeks, depending on the particular medication. And so the one that we've had around the longest is omalizumab, and there's some other ones that are coming up as well and have just recently come out. So moving on, you might see combination products, and these are when you have more than one medication in a dosage form, so more than one medication in your inhaler. And these are as effective as using the medications separately, and they're actually more convenient because then you only need to take one inhaler with you. And so some of the more common ones are Advair, which is a combination of salmeterol and fluticasone, and Zenhale, which is formoterol and mometazone, and those are both used for just maintenance or controllers. And then finally, Symbicort is the one that I've talked about or referred to more than once as formoterol and budesonide, and this is the one that's being used now for maintenance and for relief. So we've talked about the medication classes separately, and so now how do we put it all together and how do we know what to use and when? So this chart is right from the 2021 asthma CTS guidelines, and it's a management continuum. And it's a really nice picture that kind of puts it all into perspective. So the first thing that should be done is the healthcare provider should confirm the diagnosis. From there, we should think about things like environmental control and education, because remember, all of those triggers we should be avoiding and doing what we can to sort of do environmental control. The next thing to consider is a reliever medication. And so this is your short-acting beta-2 agonist, or budesonide formoterol, which is a Symbicort inhaler, and these should be used whenever you have symptoms. The next thing to think about is a controller. And so usually an inhaled corticosteroid is going to be started first, and it'll be just a low dose inhaled corticosteroid. And then if there are still symptoms, despite the fact that the inhaled corticosteroid is being used regularly and as instructed, then we can step up to either a medium dose, or we can add on a leukotriene receptor antagonist, or we can add a long-acting beta agonist, and so forth, continuing up. And then eventually, if we still need to add medications despite the fact that there's still symptoms going on, we can add things like tiotropium, and if there's very severe asthma, perhaps the biologics. So one of the things here that's important to note is that there's this arrow goes back and forth, and it's really meaning that we need to adjust therapy to continue to achieve control and to prevent future risk, but we want to reassess because asthma control varies over time, and we want to be reactive and be changing the medications depending on how you're doing. We also want to regularly reassess control, exacerbation risk, spirometry, inhaler technique, and different triggers and adherence. So as I mentioned, there's been some recent changes to asthma treatment. And so the major ones are listed on this slide. So first off, the guidelines recommend using inhaled corticosteroids very early on. So this means that almost everyone should be on an inhaled corticosteroid. So this means people who do not meet the control criteria. So if you're experiencing symptoms that are more than 2 times per week, or needing your short-acting beta agonist more than 2 times per week, or you're using more than 2 canisters per year of your short-acting beta agonist, or if you have a history of a severe exacerbation, or in people who smoke. And the reason that we don't want to use just a reliever or just our short-acting beta agonist is because even in people with intermittent and mild symptoms, they can still have severe or even fatal exacerbations. And so that's why using an inhaled corticosteroid is so important, because it targets that inflammation. So the other kind of major change here is that there is a treatment alternative for some patients. So if you are 12 or older, instead of using just your inhaled corticosteroid every day and your add-on short-acting beta agonist as needed, you can use Symbicort anytime you have symptoms. So you would just take your Symbicort inhaler, which is your budesonide and formoterol combination, and you would use it whenever you have symptoms. And because you're getting that steroid dose, inhaled corticosteroid, the budesonide, in that inhaler, you don't have to use an additional daily inhaler. And so some people might find that more convenient. So before we move on from the medications completely, I just want to talk a little bit about some of the common myths. So the first one, my asthma is well controlled with my reliever. There's no need for another inhaler. And that's kind of what we talked about before on the last slide. So really we want to use an inhaled corticosteroid early on because it does help with the inflammation. So the next one, I'm feeling better, so I should stop my asthma medications. And so when your asthma is under control, that's absolutely great. And you can definitely talk to your healthcare provider about adjusting and maybe even reducing the dose of the medications. But you definitely should not stop taking your controller medications. And part of the reason why you might be feeling better is because the inflammation is under control, and it might return if you stop completely. And so always talk to your healthcare provider before you just go ahead and stop any medication. And then the final one, I should stop my asthma medications when I'm pregnant. So pregnant mothers, they always want to do what's best for their baby. And it's very important for the baby's health to actually maintain excellent asthma control throughout the pregnancy. So in general, asthma medications are well tolerated and they're safe for, both you and the baby. Obviously, you want to discuss this with your healthcare provider. But in general, the benefits of taking the asthma medications outweigh the risks to the baby. All right, so we're going to switch gears a bit, and now we're going to talk about inhaler technique. And so this is just a fancy way of saying how to use your inhaler properly. So as we talked about, there's many different drug formulations available for the treatment of asthma. We've got inhalers, nebulizers, pills, injectables. But in general, we always want to use the inhaled route when possible. And this is because that allows the drug to get right to the lungs. That's right the site where you want it to be. And by doing so, that minimizes the side effects that we have. And so the inhaled route, although it's kind of a pain, it's not as convenient as taking a pill, it is the preferred route for that reason. So there are three main categories of devices. We have metered dose inhalers, we have dry powdered inhalers, and then we have something called a soft mist inhaler. And this could be a whole other webinar in itself, going through these devices and how to use them. But I just wanted to make sure that we touched on the couple most important or most common ones that we see in asthma. So the reason I really want to cover this, even if it's just briefly, is because using these devices is actually really hard. And most people, when they use their inhalers, do have errors. And if you're not using your inhaler properly, you're not going to get the medication. So the first one here is the meter dose inhaler, which everybody has seen before, or MDI. And here we have a canister, which has these microscopic particles that are suspended in a propellant. And then in order to have that drug released, you depress the canister and you breathe in through the mouthpiece. Sounds easy enough, right? Well, actually not quite as easy as it sounds. And so because I'm not in front of you with my inhalers on hand, I'm going to show you this wonderful little video.
Remove the cap. Shake the inhaler. Breathe out. Seal your lips around the mouthpiece and start to breathe in slowly. Press your inhaler once and keep breathing in slow and deep. Remove the mouthpiece and hold your breath for 5 to 10 seconds. Breathe out. If another puff is required, wait at least 30 to 60 seconds and repeat all these steps. Replace the cap and then rinse your mouth with water. It is recommended that a spacer device be used with this type of inhaler to help improve the delivery of medication to the lungs. These are available at your local pharmacy.
Okay, so a couple of key points about using a meter dose inhaler. So first off, holding your breath is extremely important. You want to make sure that you hold it for those 5 to 10 seconds. It's really important that you coordinate the depressing of the canister as you breathe in that slow, deep breath. And just that breath has to be slow and deep, not too fast. Another thing that we want to do is keep track of the doses. Unfortunately, not all inhalers come with a dose counter, which tells us how much is left in the medication. And so if your inhaler doesn't come with a dose counter, which tells you or keeps track of that, you have to keep track of how many doses are in your canister, because you can't tell by lifting it up or shaking it or floating it or any of those things will not be able to tell you how much is left. And then priming. So for new devices or devices that haven't been used in a long time, they need to be primed. And so what that means is just depressing the canister a couple of times before you actually use the medication with your lips around it. So there are so many errors that people make with using meter dose inhalers. So some of the more common errors for meter dose inhalers are as follows. So first off, a lot of people forget to shake it before using it. A lot of people hold the inhaler in the wrong position, or they fail to exhale prior to inhaling the medication. So you have to exhale before you inhale. Actuation, that just means sort of depressing the canister. And so some people depress that canister too early or too late. And so it has to be coordinated with your breathing. Some people inhale the medication too rapidly. Again, it's got to be a slow, deep breath. And then forgetting to shake the meter dose inhaler between the doses. So if you're taking more than one dose, you want to make sure that you wait 30 seconds to 1 minute between the dose, and you want to shake the inhaler both times. So because using a meter dose inhaler is actually a lot harder than it looks, one of the things that's recommended is a spacer. And a spacer is a tube-like chamber that we can add on to a meter dose inhaler, and that allows us to inhale the medication slowly and deeply over multiple breaths. And so it's really good for children or people that have a hard time sort of coordinating that depressing and breathing at the same time. It's actually really good for everyone because it can help decrease the side effects associated with inhaled medications. And the other thing that's really nice is you can attach a mask to it, and you can use it in very young people, just like this little guy right here. Here's another great video from the Lung Association.
Remove the caps from both the inhaler and the spacer. Shake the inhaler. Insert the inhaler into the spacer. Breathe out. Seal your lips around the spacer mouthpiece. Press the inhaler down once and breathe in slowly and deeply. If you hear a whistle, you're breathing in too fast. Remove the spacer and hold your breath for 5 to 10 seconds. Breathe out. If another puff is required, wait at least 30 to 60 seconds and repeat all these steps. Replace the caps and then rinse your mouth with water. Please note, if you are unable to hold your breath, take 6 normal breaths instead.
So one of the things that I find helpful for learning how to use a device properly is by watching someone else and trying to pick out the errors or trying to see what they do correctly. And so when my daughter was, this is quite a few years ago now, but I gave her some inhalers to play with, and I used to show these videos to my pharmacy students and have them pick out the errors. And so we'll just watch this quick little video here, and we'll see if we can determine the errors.
Okay. Be careful.
So did you catch any of those errors? There was quite a few. Probably the ones that you would notice the most easily would be 1, she didn't shake her inhaler before she put it in the spacer. 2, she put 2 doses right into the spacer. There should be a break between, and remember there should be 30 to 60 seconds or so between doses. And 3, you could hear that whistling sound when she breathed into the spacer, and that meant that she was breathing too fast. It whistles. It tells you when you're breathing too fast. Here's one more.
Okay. Really. Cap off again. Goodbye. Laugh, laugh, laugh.
So she did a little bit better this time around. She didn't put 2 doses in all at once. She did shake, which was good. What she didn't do though is she didn't take that breath out before she breathed in, which she actually didn't do on either video. She didn't wait for 30 to 60 seconds between the doses. One thing she did do well is you didn't hear that inhaler making that sound this time, and that's because she just did normal tidal breathing. So that was just normal breath in and out into the inhaler, and so that was better. So as you can see, there's a lot of things to think about, and it takes a lot of practice. So if you're ever unsure on how to use your inhaler, please, please, please ask your healthcare provider to have a look. The show and tell method works really well too. So showing them what you're doing and having them watch and seeing how it's going. Another thing is that inhaler technique actually wanes over time. So we might have it perfectly. We know exactly what we're doing when we first learn how to use the medication, but then over time we kind of forget. And so it is good to have your technique checked every once in a while and to confirm that you're doing what you should be. Okay, so moving on to the next class of devices. There's so many different ones here, and we're not going to go through them all. I think the only other one that I want to show you is that turbuhaler, because that's the one that the Symbicort is coming in now. And so that is one that might be used quite frequently.
Hold the inhaler upright and twist the cap off. Turn the base in one direction and back until you hear a click. Breathe out away from the turbuhaler. Seal your lips around the mouthpiece and breathe in quickly and deeply. Hold your breath for 5 to 10 seconds. Then breathe out. If you need a second puff, repeat these steps. When you're finished, place the cap on, twist to close, and then rinse your mouth.
So the turbuhaler is a breath-actuated device, a dry powdered inhaler, and this is one where we want to use a forceful deep breath instead of a slow breath like we did with the MDI. If you shake the turbuhaler, you will hear sort of this rattling noise, and that's the desiccant inside. So desiccant is put in there to stop the drug from clumping around. And actually, that's another thing you don't want to do is store the medication in somewhere where there's high humidity, like such as your bathroom, because it can cause clumping. One of the interesting things about the turbuhaler is you can't really taste or feel the drug, so sometimes it kind of tricks people. They don't know if you're getting a dose or not, but it's there. It's just that it's something that you can't really taste or feel. The turbuhaler is one of several different dry powdered inhalers, and each type will have its own instructions and its own way to use it. Some of the more common errors for dry powdered inhalers are not keeping the device in the correct position when either loading the dose or inhaling, failing to exhale fully before using, or failing to inhale completely, inhaling too weak or too slow, or using past the expiry date or using it when empty. So just some general tips. You want to make sure that you wait 30 seconds to 1 minute between doses of the same medication. Again, inhaler technique is actually really difficult, and depending on the study, sort of the rates vary, but it's estimated that proper technique is only used about 10% of the time, and it's really the #1 reason for therapy failure. Spacers, make sure you use a spacer whenever possible, especially in children or elderly. Common problems, we talked about some of these things already, so try and troubleshoot, try and have a healthcare provider watch you to make sure you're doing it properly. And then finally, making sure that your new device or a device that hasn't been used in a while is primed so that you're actually getting a dose of the medication. Medication adherence is a term that we use a lot in the pharmacy world, and it basically just means taking the medications correctly. So there's many different reasons why people might not take their medications. Sometimes it can be non-intentional, meaning they don't really mean to, it just happens. So they might forget. They might forget how to take it or when to take it or when to fill it or to pick it up. It might be costly and they can't afford to go pick it up. It might be confusing, especially when these inhaler devices are so hard to use. Intentional non-adherence is when people don't take their medications, but it's a choice. So sometimes people don't feel that they need it, so they don't take it. Or perhaps they fear the side effects of the medication, or they just don't want to spend the money. So there's many reasons, and I think the take-home point here is that medications don't work if they're not used and they're not used properly. And so if you ever have, any questions about the medication or concerns, or you're confused in any way, please make sure you do talk to your healthcare provider and get some help and get some clarification. And then finally, when should I contact my healthcare provider? So obviously, concerns about medication or needing advice about medication would be one reason. Another would be not having control. So using your inhalers or having symptoms at least 2 times per week, having nighttime symptoms, having exacerbations, or leaving work or school due to asthma. So any of those things can indicate not having control, and it's really important that you do see your healthcare provider to sort of help fix that. An action plan is another thing that can help you know when to seek medical advice. And for those of you who don't have an action plan, it's basically recommended for patients with asthma, and it is a specific plan that is just for you, and it tells you how to monitor your symptoms and to measure them. It outlines daily preventative management strategies. It outlines how to adjust your medications if you need to, and when to seek urgent care. And so an asthma action plan is a strategy that you can use to manage your symptoms when they get out of control. And studies have actually shown that having this written agreement or action plan can help you to manage your symptoms and have better control of your asthma. And so if you don't have an action plan, I encourage you to talk to your healthcare provider. There are many different templates that can be downloaded to help you sort of work through this. This is one that was from the Lung Association, and so the website is below as well. And yeah, it's just a really good way to sort of know what you're doing with your therapy and when to get help. And so that is the end of my slide deck, so I will stop talking. And I just want to thank you for your attention today, and also a big thanks to the Lung Association and to GlaxoSmithKline for sponsoring this event. And I'm happy to take any questions.
Thank you so much, Dr. Mansell, for your amazing presentation and for giving us such wonderful information about the asthma medications and asthma control. We certainly appreciate it. And I have to say, your daughter, it's just adorable. I loved watching those videos of her. I'm sure many other people did as well. So we have time for some questions. And if you have any questions for Dr. Mansell, please don't be shy. Go ahead and ask them. You can do so by just typing your question right in the question feature. You should see that in the panel there, and we'll do our best to try and get to it. So Dr. Mansell, if you're ready, I have a few questions here that have been submitted throughout the webinar. I'll go ahead and maybe ask the first one. And the first one is, do some medications in the same category or class, for example, of a combination inhaler work better for certain types of asthma? So for example, you saw many different options of combination inhalers, and would one combination work better depending on, for example, if someone had allergic asthma?
Thanks, Jill. That's a great question. If we look at the different classes of medications, some classes actually do work better because of the way they work. So we talked about corticosteroids, for instance, how they're pretty much the best controller that we have because they work so well on that inflammation, which is really what causes our symptoms. And this would be true for all kinds of asthma, really, whether it's related to allergies or not. But I'd have to say if we compare the different types of corticosteroids, so within that class, there isn't really any evidence to say that one is better than the other.
Perfect. Thank you. That was a great answer. Thank you for clarifying that. All right. Do dry powdered inhaler medications or get as deep into the lungs as, for example, a medication that you can take with a metered dose inhaler and perhaps a spacer?
Oh, that's a good one. I don't actually know of any studies off the top of my head that are comparing the two scientifically, but I do know that within the dry powdered inhalers, there's not really one that's been shown to be better than the others. And my best guess would be if you're using them both perfectly, there's probably no difference in terms of effect. However, it's really hard, as we talked about, to use them perfectly. And so, it is a personal sort of preference with what type you use and how you find using it. But I would say that probably the MDI plus the spacer would be easier than some of the DPIs, not the MDI alone. I mean, that's pretty tough, but using a MDI plus a spacer is probably a little bit easier. I'm not sure if that answers the question, but
No, thank you for that. So really, um, you know, taking your inhalers properly, no matter what type, whether it be a meter dose inhaler and spacer or a dry powdered inhalers is key. And you showed us some great resources that people can look to, those videos, as well as whenever they have questions, ask their healthcare provider, whether it be a respiratory educator or a pharmacist such as yourself. Yeah.
absolutely. That's a take home point.
Perfect. Okay, here's another great question. Could you briefly describe some of the side effects that are often seen with biologics? So that was the type of medication that you showed, or type of class that you showed for severe asthma.
Yeah, okay, that's a good question too. So, I'll be honest, I don't deal with a lot of patients who are on biologics, so it's not something that I typically see. But the textbook answer would be things related to injection site reactions. So maybe pain at the site, or perhaps inflammation, that sort of thing. And they also recommend, depending on which one it is, that you are in a healthcare facility so that you can be watched by a healthcare provider just to make sure there's no allergic reaction. So, yeah.
Okay. Okay, perfect. Thank you so much. All right. Could you again address if asthma medications, how we know for sure if they're safe for women that are pregnant? There's a lot of concerns about taking their medications, also dosing. Should they decrease their medication when they become pregnant? Could you touch on that again? I know you did speak to it in the presentation.
Yeah, for sure. So I'll just start out by saying that the risks of not having controlled asthma while you're pregnant are pretty high. So things like preterm births or low birth weight or increased blood pressure for the mother are all things that can happen. But if somebody's asthma is well controlled, the risks of their risk is really the same as the general population. And so that's why it's just so important that we have our asthma well controlled when we're pregnant. And so the short answer would be yes, like absolutely. It's most important to take your medications and take them the way that they're prescribed. Um, of course, I would absolutely also tell you to talk to your healthcare provider too, because they might want to tweak the therapy a bit depending on your situation. But yes, they definitely taking the medications during pregnancy outweighs the risk.
Great, thank you for that. I'm sure that's reassuring for many people to hear that as well. It's yeah, every treatment plan can be individualized, but thank you for that answer. Okay, this is also a great question for kids with asthma. When do you know when to transition your child from using a metered dose inhaler and spacer with a mask and a metered dose inhaler and just the spacer alone?
Oh, that's a good one too. Um, So I would say if they are able to do it on their own without you having to put the mask around them, then it's probably safe to transition them. Again, you want to talk to your healthcare provider and have that assessed. But a 5-year-old, for sure. My daughter in that video was not that much older than 5. She could do that, but if there's any doubt whatsoever, you absolutely want to use the mask to make sure you're getting the dose.
Perfect. Thank you. Yeah, and all kids are different, but for sure that's a great answer. Thank you. Okay, so you showed so many different asthma medication options for each class, and they have a lot of the same indications. Well, this question is about how do people know when they're newly diagnosed which one their healthcare provider should put them on first? Is some of it just trial and error, or or is there something that they can follow? How do people know what to do?
Yeah, also a great question. So we did talk about the asthma continuum there, which kind of shows us our step-by-step approach. So usually you do start with, of course, a reliever medication, and you add on a steroid very quickly, an inhaled corticosteroid. So it's the inhaled corticosteroid class that we would use. But we talked about all of the different types of inhaled corticosteroids, and so there are some choices within that class. And again, there's no real evidence to show that one is more effective than the other. So one type of inhaled corticosteroid is more effective than the other. And so at that point, it comes down to other factors. So different medications are in different devices. Some will come in a metered dose inhaler, whereas other will be in a dry powdered inhaler and a different type of dry powdered inhaler. And so for many people, it's a personal preference, which one they prefer to use over the other, or it could be the age of the child, like we kind of talked about, or other factors that might be into play would be how many times a day that you need to take the dose, or cost or coverage by the drug plan, so all kinds of little things that come into play. But I think the most reassuring thing is that they all work, and they all work really well.
That's awesome. Thank you. Thank you for that answer. That was helpful. Okay, this is another great question. Can your medication become less effective over time the more I take it?
Ooh, that is a good one. So, and the answer is it really depends on the drug or the class of the medications. So with our inhaled corticosteroids, unfortunately not, they work for us and they work well. But with our beta agonists, they actually can become less effective. It's not so much the potency, it's they wear off faster if we're using them over and over and over. And so it's the duration of effect. So that's really, one of the risks of overusing your short-acting beta agonist. But the other good thing about using your inhaled corticosteroid is when we use them together, that kind of negates that. And so your short-acting beta agonist will work the way that it needs to work when you need to use it.
That's perfect. Thank you. Thank you for explaining that. Okay, so you touched on in the myth section of your presentation, you touched on um, talking about some of the concerns around children with inhaled corticosteroids, and that sometimes they can um, see long-term side effects from taking steroids, right? And steroids are kind of a scary word. So can you just reinforce and explain again? There's some questions around the growth piece that can happen, and if children do in fact catch up.
Yeah, that's a really common question. And I think every parent needs to hear this over and over because it's really important. So yes, we do know that corticosteroids can sort of affect the growth pattern. But the good news is one, it's dose related. So using lower doses means there's less risk. And even using moderate doses, it seems to be quite well. And some studies show that the child should achieve the predicted height, even with that. Um, and then we also have to think about the risks of not using the corticosteroid. So if you have a sickly child that is not doing well and thriving, then the risk there is that they're not going to grow properly either. And so with the whole growth thing and inhaled corticosteroids, the decline would be right off the bat within the first year that we would see that, and it would be very, very small. And generally they do catch up at adult height. And even if you use really, really high doses, the most that you would probably see is like less than a centimeter. So again, benefits outweigh the risk.
Okay, perfect. Thank you. Thank you. I know that's a lot concerns for many patients and particularly parents. So thank you. Okay, so you talked about the importance of rinsing your mouth after using your inhaler, um, and you talked about the risk of infection called thrush. Is that the only risk, and is there any other reason why we should be rinsing our mouth afterwards? And to add to that, do we just rinse with water, or should we do warm water and salt, or something else like a mouthwash?
Oh, good questions. Okay, so we always tell our patients to rinse out their mouth after using their inhaled corticosteroids specifically, and warm water should be fine, or whatever you have is fine, and it's a gargle and spit. So of course you don't want to swallow the water that you have. There's no need for a fancy mouthwash. Water is okay. And there's kind of two reasons that I think about why we would do that. So the first one, like you said, is of course with the thrush. So we want to prevent that throat infection that could happen, or maybe the other side effects, like maybe some hoarseness can help with that as well. But the other reason is that it can help really to just kind of, what was I going to say? I lost my train of thought here. No, sorry. I'll just stop there. I'm rambling.
No, that's just fine. So it's really to prevent the thrush, and just
Yeah,
gargling and spitting with water is what you recommend.
absolutely.
Okay, perfect. Well, those are all the questions that have been submitted. So if you have any other questions for Dr. Mansell, please go ahead and submit them into the question feature. If questions continue to roll in after the webinar is over, we'll do our best to submit those questions to Dr. Mansell and see if we can get them answered to you. So I think I'm not seeing any further ones come in, and you answered all those questions so well and so eloquently, and I think you did such a great job explaining so much of the content in your presentation. I think people have learned so much about their asthma medication and control, and I know you've answered a lot of their questions and concerns, so thank you. So before we wrap up tonight, I just want to again thank our sponsor, GSK. They really made this possible. And I want to thank all of you for taking time to learn about asthma medications and control. And we really hope that what you learned from this webinar will empower you to get better control of your asthma if it isn't already controlled, and just really empower you to breathe just a little bit easier. So thank you. And if you're not already a member of the Lung Association of Saskatchewan's Asthma Support Group, we encourage you to join. We'd love to have you. You can simply go on our website and find out more at lungsas.ca. And our asthma support groups really are an opportunity not only to share your journey and support others, but also to find out about other educational opportunities just like this one. And lastly, please kindly consider supporting the Lung Association of Saskatchewan by making a donation today. So thank you for joining us tonight. We hope you enjoyed the webinar. Thank you, Dr. Mansell. Have a good night.